Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Welcome to the Deep Dive. Today we are focusing on one of the most, exciting and frankly, sometimes terrifying advances in modern medicine.
That's right.
We're talking about cellular and gene therapies, specifically chimeric antigen receptor T-cell therapies, CRT.
Mm-hmm.
Our senses, and there are quite a few we've looked at for you, they consistently call this a true paradigm shift. Especially for patients with stubborn hematologic cancers. It's offering incredible efficacy where, older treatments just weren't cutting it.
It really is the definition of revolutionary medicine. I mean, we're engineering a patient's own T cells, turning them into these precision missiles, really, trained specifically to hunt down and kill cancer cells.
Amazing.
The results are unprecedented. But, and this is the core of our deep dive today, the mechanism itself, this incredibly potent, targeted immune activation, it's a double-edged sword.
Right.
It means clinical teams have to be absolutely ready to manage a set of unique, potentially explosive toxicities that come along with it.
Exactly. This isn't your standard chemo side effects like nausea or hair loss. This is different. We're talking about the patient's entire immune system being kind of weaponized. And if we're going to use this therapeutic power safely, we have to understand and maybe more importantly, control the potential chaos that results.
And that chaos, it really boils down to two main syndromes that we absolutely have to get into today.
Okay.
First, there's cytokine release syndrome, CRS. Think of it like an acute systemic inflammatory cascade, a body-wide wildfire, really sparked by that T-cell activity.
A wildfire. Okay.
And second, and this one can be trickier, often more subtle but just as dangerous, is immune effector cell-associated neurotoxicity syndrome, ICANS.
ICANS.
It's a distinct, complex neuropsychiatric disorder. It involves the central nervous system.
So our mission for you today is, it needs to be rapid, comprehensive, and really action-oriented. We're not just going to define these things.
No.
We're aiming to establish the non-negotiable framework for managing them effectively. That means understanding the tools for precise, standardized assessment, things like the ASTCT grading, the absolutely critical ICE score.
Indispensable.
And then translating those findings into immediate action using specialized rapid response systems or RSM and really detailed grade-specific treatment protocols because, failure here just isn't an option.
Absolutely not. The stakes are too high.
Okay, let's unpack this a bit more. We have to start with the foundational pathophysiology, right? Because the why, the biological reason, how CRS and ICANS start, that's really our guide for how we treat them differently.
Exactly. Understanding the mechanism is key to the management.
So starting with CRS, that systemic inflammatory cascade. We know the CRT cells get activated, but what's the immediate sort of explosive reaction happening inside the body?
Okay, so CRS is an acute systemic thing, and importantly, it's an on-target consequence of those CRT cells finding their antigen on the tumor cells.
On target, meaning it's doing its job initially.
Precisely. When they bind to the tumor cell, they start their cytotoxic function. They kill the cell. Often this happens through a specific type of inflammatory cell death called pyroptosis.
Pyroptosis, okay, that sounds fiery.
It is, and it's not quiet cell death. It results in the release of all the intracellular contents.
Yeah.
And the immune system sees these contents as powerful distress signals. We call them damage-associated molecular patterns, or DAMPs.
Right, DAMPs. So the CAR T cells, they light the initial match by killing the tumor cells, releasing these DAMPs, which are basically like smoke signals for the rest of the immune system.
That's a great way to put it. But here's the pivotal distinction, the thing clinical teams really need to grasp. The CAR T cells themselves, They aren't the primary source of the massive systemic inflammation we see in really severe CRS.
Ah, okay. So it's not just the CAR T cells going wild.
No. The massive, dangerous cytokine storm is largely driven by bystander immune cells. They get recruited by those DAMPs and the initial cytokines the T cells release.
Bystander cells.
The primary culprits are the activated myeloid cells, specifically macrophages and monocytes. They become hyperactivated by the initial signals and start spewing out huge quantities of pro-inflammatory mediators. That's what creates the systemic cascade.
So focusing only on suppressing the T cells wouldn't be enough?
Exactly. You'd miss the main driver of the symptoms, the real source of the storm.
Okay, so if these macrophages and monocytes are orchestrating this chaos, what's the single most damaging conductor in this whole cytokine orchestra? What mediator should we really focus on?
That is undeniably interleukin-6, IL-6.
IL-6.
Our sources are very, very clear on this. Elevated levels of IL-6 correlate strongly, almost linearly, you could say, with the severity of CRS.
So more IL-6 means worse CRS.
Directly.
Yeah.
IL-6 drives the hallmark clinical features you see. That unremitting high fever, the severe tachycardia, that dramatic spike in C-reactive protein, the CRP level.
Right.
But perhaps most dangerously, IL-6 causes endothelial activation and damage all across the body.
Endothelial damage.
Yeah.
And that translates into what we call capillary leak syndrome, right? Can you explain that for the listener? Why does IL-6 damaging the endothelium lead to the really dangerous symptoms like shock?
Sure. Capillary leak syndrome means exactly what it sounds like. The walls of the tiny blood vessels, the capillaries they're lining, the endothelium becomes permeable, leaky.
Leaky vessels.
Yeah, IL-6 basically damages the tight junctions holding those endothelial cells together.
Yeah.
So fluid, proteins, plasma. It all starts leaking out of the vascular space and into the surrounding tissues.
Okay, I see.
When too much fluid leaks out, the effective circulating blood volume just plummets. And that's why you see profound, often refractory hypotension, low blood pressure that's hard to treat, and fluid accumulation, like edema in severe CRS. It's essentially a distributive shock state, driven by inflammation damaging the vessels, not necessarily by the heart failing.
And typically, when does this fire, the CRS, tend to start after the CRRT infusion?
It's generally acute. It peaks usually within the first week and almost always within the first 14 days post-infusion.
So early onset, mostly.
Mostly, yes. And we also know certain factors definitely heighten the risk. Patients who start with a very high tumor burden, for instance, they just have more initial cells for the CAR Ts to kill, which means more DAMPs released right at the start.
Makes sense. More fuel for the fire.
Exactly. Also, the specific CAR T cell product itself matters, the design. Those utilizing the CD28 costimulatory domain, for example, often trigger a faster T cell expansion, and that correlates with a higher incidence of severe early onset CRS compared to, say, 4-1BB constructs, which tend to have a slower, maybe more durable expansion profile.
Okay, that really sets the stage for CRS. Now let's pivot. Let's talk about ICANS, the neurotoxicity. If CRS is this systemic body fire, how does that translate into a specific complex disorder affecting the brain?
Right, ICANS. The leading hypothesis, the one that seems to tie everything together, really hinges on the structural integrity of the brain's protective barrier, the blood-brain barrier, BBB.
The BBB.
Okay. That systemic inflammatory environment we just talked about with CRS, all those high circulating levels of IL-6 and other cytokines, it doesn't just damage the endothelium, the vessel lining, out in the periphery. It damages the CNS vasculature too, the blood vessels in the brain.
So this systemic inflammation basically breaches the brain's defenses.
It fundamentally disrupts the tight junctions of the BBB, makes it permeable, leaky, just like the capillaries elsewhere.
So that's the critical connection. The systemic inflammation breaks that protective seal and allows the chaos, so to speak, into the control center.
Precisely. That compromised barrier lets inflammatory factors, cytokines, those activated monocytes we mentioned, even some T cells perhaps, to influx, to flow into the very sensitive CNS parenchyma, the brain tissue itself.
And once those inflammatory factors are inside the brain?
Once inside, they trigger a distinct, localized inflammatory response. This involves the brain's own resident immune and support cells, things like astrocytes, parasites, and really importantly, the microglia.
Microglia, the brain's immune cells.
Exactly. And the sources pointed to a very specific internal mechanism driving that localized damage inside the brain. It's not just general inflammation.
Okay, can you elaborate on that? What's happening locally?
Yes. So recent evidence, mostly preclinical, but it's highly instructive, indicates that within the CNS, it's specifically microglial activation, those brain macrophages, via the TK1 and P38 MAPK signaling pathways. That's what seems to drive the specific neuronal dysfunction and the resulting neurotoxicity we see as ICANS.
Interesting. So IL-6 is maybe the systemic villain, but these localized pathways, TK1 and P38 MAPK, are the key drivers of the neurological symptoms themselves.
That's the current thinking. And this distinction really emphasizes that ICANS isn't simply a side effect of CRS. It's more like a secondary distinct inflammatory disorder that's catalyzed or set up by the CRS environment and the BBB breach.
Okay. And since the mechanism seems so localized within the brain, the clinical signs must be, well, potentially quite subtle at first. What are the earliest signals clinicians absolutely must be watching for?
Vigilance is paramount here, especially around subtle changes in, like, higher cortical function. The very earliest sign is often just diminished attention or difficulty concentrating. Patients might seem a bit foggy.
Subtle, yeah.
Another really pivotal early sign is expressive aphasia, specifically anomia, which is word-finding difficulty. The patient might substitute words or pause frequently, searching for the right word when speaking.
Word-finding trouble. Okay.
Additionally, you need to watch for tremors and also dysgraphia. This is a rapid, often quite visible deterioration in the patient's handwriting. Ask them to write a simple sentence. It can be very revealing.
Dysgraphia handwriting changes. That's a concrete sign.
It is. And as it progresses, unfortunately, we start to see things like global aphasia, more severe altered consciousness, starting perhaps with somnolence, sleepiness, and potentially progressing to coma. Motor weakness can develop, and even seizures.
And what about the timing? Does ICANS typically show up after the CRS has started or even peaked?
Yes, most often it does. ICANS typically follows the resolution, or at least the peak, of CRS. The median onset is often around day 4 or 5 post-infusion.
Later than the typical CRS peak.
Right. And this timing strongly supports that hypothesis we talked about. The systemic CRS sort of primes the CNS, disrupts the BBB, setting the stage for neurotoxicity to develop later.
Which leads to a critical predictive insight, doesn't it?
It absolutely does.
Yeah.
Severe early onset CRS is one of the most significant risk factors we know for developing subsequent high-grade ICANS.
So managing CRS well early on might actually help prevent bad ICANS later.
That's a pivotal proactive strategy. Aggressive and effective management of the CRS early is probably one of the best things you can do to mitigate the risk of severe ICANS down the line.
Okay, so given how quickly these toxicities can escalate, relying on just a subjective feeling, that the patient doesn't seem right, or some generalized clinical impression, it's just too dangerous.
Not precise enough. Not at all. And that brings us directly to the ASTCT consensus grading criteria. That's the American Society for Transplantation and Cellular Therapy. These criteria are the indispensable foundation for standardized assessment. Everyone needs to be using the same language.
Right. Standardized grading. Let's break down the ASTCT grading for CRS first. You mentioned 3 core parameters earlier. How do we use those to actually grade the severity, say from grade 1 up to grade 4?
Okay, the 3 core parameters, the non-negotiables, assuming they aren't clearly due to something else like sepsis, are fever, specifically a temperature over 38 degrees Celsius or 100.4 Fahrenheit, hypotension, low blood pressure needing either IV fluids or vasopressor drugs, and hypoxia, low oxygen levels needing supplemental oxygen.
Fever, hypotension, hypoxia. Got it.
Those are the pillars.
Now, there's a crucial nuance you mentioned regarding fever. It's a point that, if it's misunderstood, could lead to, well, prematurely de-escalating care, right?
This is a potentially life-saving nuance. Absolutely critical. Fever is required for the initial diagnosis of CRS. You need that fever spike to say, okay, this looks like CRS starting.
Right.
However, once the patient receives targeted anti-cytokine therapy, the main one being tocilizumab or corticosteroids, that fever might resolve quite quickly because the treatment is working on that symptom.
So the fever goes away because of the meds.
Exactly. But the grading of the severity of the ongoing CRS must then be based solely on the continuing needs for hemodynamic support, the hypotension, and respiratory support, the hypoxia.
Ah, okay. So even if the fever's gone because of Toshi or steroids, if they still need pressors for blood pressure...
They are absolutely still high-grade CRS. A patient who is a febrile due to treatment but still requires, say, a vasopressor to maintain their blood pressure is still experiencing significant ongoing CRS, likely grade 3 or even 4, depending on the support level. They must be managed aggressively. Ignoring this rule, just looking at the temperature, risks catastrophic undertreatment.
That is a vital point. Okay, so focusing on those support needs then, what's the practical difference between, say, grade 2 and grade 3 CRS? What does that look like at the bedside?
Grade 2 is really the threshold where urgent intervention becomes necessary. It's defined by needing low-flow oxygen, usually meaning less than 6 liters per minute via a standard nasal cannula or hypotension that is responsive just to giving IV fluids. Simple fluids bring the pressure back up.
Okay, low flow O2 or fluid-responsive low BP, that's grade 2.
Right. Grade 3 is a sharp escalation from there. This patient now requires high-flow oxygen, think something like a face mask, maybe a non-rebreather mask, and/or they require a single vasopressor medication, like norepinephrine, just to maintain their blood pressure.
High flow O2 or needing one pressor, that's grade 3.
Correct. And then grade 4, that's the worst case scenario. That's typically needing multiple vasopressors, often requiring positive pressure ventilation, meaning the patient is intubated or needs non-invasive support like CPAP or BiPAP, really life-threatening organ dysfunction.
Got it. That level of detail is clearly necessary for quick, accurate triage. Now, shifting to ICANS. Those neurological symptoms, as you said, can be so subtle initially. How do we objectively screen for that cognitive decline before it gets really bad?
Yeah, this requires a different approach. It needs proactive serial surveillance. You can't wait for the patient to become obviously confused. And the cornerstone tool for this is the 10-point immune effector cell-associated encephalopathy score, the ICE score.
The IC score, okay.
It's specifically designed as a rapid, pretty reliable bedside screening tool. It doesn't take long to do. And the protocols, the guidelines, insist the score must be assessed at least twice daily, minimum, for every single patient at risk following CRRT infusion.
Twice a day, minimum. And what's the trigger?
Any decline from their baseline score. Most patients start at a baseline of 10 out of 10. So a drop, even just a 9, is the earliest possible alarm bell for ICANS.
Okay, let's walk the listener through those 5 domains that make up the 10 points. What exactly is the nurse or the clinician testing when they do the ICE score?
It's designed to be quick and cover key cognitive areas. So 4 points are for orientation, asking the patient the current year, the month, the city they're in, and the hospital name.
Orientation, 4 points.
Then 3 points are for orient, naming 3 common objects you can see in the room. You might point to, say, a key, a pen, and maybe the clock on the wall. Can they name them?
Naming, 3 points.
1 point is for following a simple command. Something straightforward like close your eyes and then touch your nose.
Command following, 1 point.
Another point is for writing a dictated sentence legibly. You give them a simple standard sentence like the quick brown fox jumps over the lazy dog, or even simpler, and see if they can write it clearly. This is where you might pick up that dysgraphia we mentioned.
Writing, 1 point. Checks for dysgraphia.
Exactly. And the final point is for attention, usually tested by asking them to count backwards from 100 by 10s. Can they maintain focus?
Attention, 1 point. So 4 plus 3 plus 1 plus 1 plus 1 equals 10.
That's it. And it's a powerful little assessment because a subtle change in their ability to do any one of these tasks, especially that handwriting deterioration or the word-finding difficulty showing up in the naming task, gives you the earliest objective indicator that something might be going wrong in the CNS.
Okay. And how does that raw ICE score then translate into the final ACCT ICANS grade from 1 to 4?
The final ICANS grade, the official grade, is determined by the most severe neurological finding across 5 different domains. But the ICE score is the primary anchor for assessing the cognitive status component.
Okay.
So roughly grade 1 ICANS corresponds to an ICE score of 7 to 9. The patient is awake, easily aroused, but showing some deficit on the test.
7 to 9 is grade 1.
Right. Grade 2 is a significant step down. That's an ICE score of 3 to 6. And critically, at this level, the patient typically only awakens to voice. You have to call their name to rouse them.
3 to 6, awakens to voice. Grade 2.
Correct. Once the score hits grade 3, which is an ICE score of 0 to 2, the patient usually only awakens to tactile stimulus, like a shoulder shake. Or they might be having seizures or showing signs of elevated intracranial pressure.
0 to 2, awakens to touch or seizures. Grade 3.
Yep, and grade 4 is the most severe. The patient is unarousable, essentially comatose, potentially with life-threatening signs like ongoing seizures, status epilepticus, or severe cerebral edema. The IC score would be 0 and they wouldn't respond even to touch.
Grade 4, unarousable. Okay, that framework, ASTCT for CRS and ICE plus ASTCT for ICANS, seems absolutely critical for standardization.
Absolutely. And these standardized grading systems, plus the mandatory proactive monitoring protocols, using the ASTCT grades, doing those twice daily IC scores, they form the crucial afferent limb. That's the triggering mechanism, the input signal for a specialized rapid response system, or RS.
Yeah, the afferent limb. The system has to detect the problem accurately first.
Exactly. The signal has to be clear and reliable, and then That signal has to translate into immediate coordinated action from the response team.
Okay, so we've identified the high-stakes deterioration using these tools. What are the specific sort of non-negotiable triggers that should make someone pick up the phone and call the rapid response team, the RRT, going beyond just standard vital sign triggers like a low BP?
Yeah, standard triggers are necessary, of course, like a systolic blood pressure dropping below 90 or a heart rate suddenly going way too high or too low. But for these RRT patients, the CGT-specific triggers are paramount. They often signal trouble before the standard vitals crash.
Okay, what are they?
For CRS, the key trigger is any new requirement for supplemental oxygen. If the patient was fine on room air, and now they need even just a nasal cannula at 2 liters.
Even low flow.
Even low flow. By definition, that means they have hit at least CRS grade 2, and the RRT must be called immediately. No delay.
New O2 need means grade 2 plus CRS, call RRT.
Got it.
And for ICANS?
For ICANS, the trigger is any decline from their baseline ICE score of 10. If that patient scored a perfect 10 this morning, and now this afternoon they score an 8 or a 9.
Even just 1 or 2 points down.
Even 1 point down. That technically signifies ICANS grade 1 has developed, and the RRT must be activated instantly. You cannot wait for them to become somnolent. That subtle cognitive change is the first domino.
Wow, okay. Any drop from baseline ICE-10 triggers the RRT. That's a sensitive trigger.
It has to be. And we also have to ensure the system is designed so that, well, the human element can override the strict protocol if needed, right?
What do you mean?
I mean, the system has to create psychological safety for the staff and family. The RRT activation structure should always include and empower the bedside nurse or even the patient themselves or a worried family member to activate the RRT if they simply sense something is wrong. Even if the vital signs look okay on the monitor and the ICE score hasn't officially dropped yet, that clinical intuition, that gut feeling, needs to be respected.
That's crucial, empowering the front line. Okay, let's talk about the specialization required within the RRT itself. Why isn't a general critical care response team usually sufficient for these complex CRT toxicities? What's the ideal composition for this kind of response?
Right. The core team members you'd find in any RRT, the critical care nurse, the respiratory therapist, the hospitalist, or critical care physician, they're absolutely essential for the initial stabilization. Managing airway, breathing, circulation, the ABCs.
Standard critical care is needed first.
Yes, but their standard response toolkit fluids, oxygen, maybe starting a general pressor like norepinephrine, it's fundamentally insufficient on its own because it doesn't treat the underlying immunopathology driving the CRS or ICANS.
Ah, okay.
Yeah.
They can stabilize but not fix the root cause.
Precisely. So this RRT must have immediate direct consultation access to the cellular therapy specialist, the oncologist or BMT physician overseeing the CRT treatment. And critically, the RRT itself must have the institutional authority and the protocols in place to deploy highly specific immunomodulatory agents.
Meaning they need to be able to quickly give drugs like tocilizumab or high-dose steroids, which a general RRT might not typically be trained on or even allowed to administer without multiple consults.
Exactly that. This delay can be fatal, which is why institutions doing a high volume of CAR T-cell therapy should really strongly consider establishing a specialized immuno-oncology emergency team, or IOET.
An IOET.
Yeah. This team is deliberately multidisciplinary. It should include expertise from oncology, critical care, maybe neurology, and definitely pharmacy. And this specific team is trained extensively in the nuances of ASTCT grading, the RRT triggers we just discussed, and crucially, the immediate grade-specific drug protocols needed. They can act faster and more decisively.
Makes sense. Okay, so the specialized IOET arrives at the bedside. After stabilizing the ABCs, what is the most pivotal and non-negotiable next step they must take immediately, beyond just assuming it's CRS or ICANS and starting treatment?
This is maybe the moment of highest risk for a catastrophic misdiagnosis. The absolute priority, done concurrently with stabilization, is to rapidly initiate a differential diagnosis workup.
Rule out the mimics.
You have to. Think about it. CRS often presents as fever, maybe low neutrophils, tryptopenic fever, and shock. What else looks exactly like that in these often immunocompromised patients?
Sepsis?
Yeah.
Bacterial infection?
Exactly. Sepsis is common, especially with neutropenia, and it looks identical initially. So the IOET must stabilize the patient while simultaneously ruling out infection. That means drawing blood cultures immediately, starting a thorough infectious workup, and often starting empiric broad-spectrum antibiotics right away especially if the patient is neutropenic.
Because you absolutely don't want to give high-dose steroids which suppress the immune system to a patient who actually has an untreated bacterial infection, right? That could be disastrous.
It could be fatal, but delaying the specific treatment for severe CRS or ICANS is also potentially fatal.
Right.
It's a real clinical tightrope walk that requires rapid diagnostics and expert judgment.
A true emergency. And similarly for the neurological changes with ICANS, need to rule out other brain issues.
Yes. For any neurological change, especially ICANS grade 2 or higher, they must immediately consider and start ruling out mimics. Is this a stroke? Is it a CNS infection like meningitis or encephalitis? Is it a metabolic encephalopathy from organ failure? This usually requires urgent neuroimaging, getting a STAT CT scan, or even an MRI of the brain.
So the RRT-IOET role is incredibly complex right at the start. Stabilize life threats, rapidly try to confirm if it is quercitins, while simultaneously ruling out the dangerous mimics, all so they can initiate the correct, highly specific immunomodulatory therapy as fast as possible.
That's the challenge. It requires protocols, expertise, and seamless teamwork.
Okay, so once that diagnosis CRS or ICANS and its grade are reasonably established, the RRT or IO, that has to pivot instantly to the specific pharmacologic management. And this is where you mentioned standardized order sets, or SOSs, become absolutely indispensable. Why are they so critical here?
They're critical because they prevent confusion and delays when literally seconds matter. These situations are high pressure. Trying to remember complex dosing, infusion rates, conditional logic for escalation, it's prone to error.
Right, too much to recall under stress.
Exactly. SOSs, ideally built right into the electronic health record, EHR, are mandatory for translating these complex, nuanced guidelines into timely, actionable, grade-specific care. They take the guesswork out, they ensure the right drug, at the right dose, via the right route, is ordered and given without dangerous delays. It's about minimizing variance and maximizing speed and safety.
Okay, makes perfect sense. Let's get specific then, starting with CRS management. If the patient triggers the RRT call because they've hit grade 2 CRS or higher, what is the first-line targeted therapy and what's the rationale behind it?
The first-line targeted therapy, the go-to drug for CRS grade 2 or higher, is tocilizumab.
Tocilizumab.
Okay. It's typically dosed at 8 milligrams per kilogram of body weight, given intravenously, usually with a maximum single dose capped to 800 milligrams. And it's infused over about an hour.
And the rationale. Why Tochi first?
It flows directly from the pathophysiology we discussed earlier. Tocilizumab is a monoclonal antibody. Its specific job is to act as an interleukin-6 receptor antagonist.
It blocks the IL-6 receptor?
Precisely. By blocking the receptor where IL-6 would normally bind, it immediately targets that central driver of the systemic endothelial damage and the capillary leak syndrome. It's aimed right at the heart of the CRS storm, and it often works quite fast to help stabilize hemodynamics, reduce fever, and decrease oxygen needs.
Okay, so Tochi hits the IL-6 pathway hard and fast. What's the escalation path if, say, that first dose of tocilizumab doesn't achieve enough clinical improvement within a reasonable time frame, maybe 6 to 8 hours?
Right. If the grade 2 or higher CRS persists, meaning the patient is still hypotensive needing fluids or pressors, or still requires supplemental oxygen despite the Tochi, then you need to escalate. You can consider giving a repeat dose of tocilizumab, especially if it's been at least 8 hours. However, often, the next step in the protocol involves adding systemic corticosteroids at this point.
Adding steroids on top of the Tochi.
Yes. Typically, that would be dexamethasone, often at a dose of 10 milligrams IV every 12 hours. The steroids provide broader anti-inflammatory effects.
Okay, and what about for the most severe cases? The patient who comes in or rapidly progresses to grade 4 CRS, life-threatening.
Grade 4 requires immediate ICU admission, obviously. These patients often need multi-agent vasopressor support to maintain blood pressure, maybe mechanical ventilation, and they require the maximum intensity immunomodulation we have available. That means high-dose pulse steroids, specifically methylprednisolone, usually given at a very large dose, 5 milligrams IV daily.
Wow, 1,000 milligrams of Solumedrol daily.
Yes, typically for a minimum of 3 consecutive days. This massive dose is really necessary to try and halt the widespread inflammatory damage and the severe capillary leak that's causing the organ failure. Tocilizumab, if they haven't hit the maximum allowed doses, might be continued concurrently to keep hitting that IL-6 pathway, but the high-dose steroid becomes the cornerstone for grade 4.
Okay, maximum effort for grade 4 CRS. Now, let's pivot entirely over to ICANS management. If the RRT is called for ICANS grade 2 or higher, we know this is primarily a CNS disorder affecting the brain, so the treatment philosophy must change dramatically, right? What's the non-negotiable core principle here?
Yes, completely different primary target. For ICANS grade 2 or higher, the absolute non-negotiable first-line treatment is the immediate initiation of high-dose corticosteroids.
Steroids first for ICANS.
Steroids first and foremost. The standard protocol for grade 2 or grade 3 ICANS is typically dexamethasone, usually 10 milligrams IV every 6 hours. So a higher frequency than we might use for CRS escalation.
Dex 10 milligram IV Q6 hours.
Okay.
And how long do you continue that?
That dose is generally continued until the ICANS symptoms resolve back down to grade 1 or ideally completely resolve, grade 0. At which point, a slow, controlled steroid taper can begin. The rationale is that steroids are the most potent immediate agents we have to reduce that localized inflammation and microglial activation happening inside the CNS. They penetrate the BB well, especially dexamethasone.
Okay, steroids are key for the brain inflammation. Now, we absolutely must address the critical safety distinction here. Why is tocilizumab, which is so effective for CRS, generally not recommended as the primary or sole therapy for isolated ICANS?
This comes back to the blood-brain barrier again. Tocilizumab is a large monoclonal antibody. It simply does not cross the intact or even a slightly leaky BBB very effectively.
You can't get into the brain easily.
Right. So if you only treat isolated ICANS, meaning ICANS without significant concurrent CRS, with tocilizumab, you are essentially not treating the localized microglial inflammation that's actually occurring inside the brain parenchyma.
Yeah.
You're missing the target site.
Okay, that makes sense.
Furthermore, there's even some clinical concern, maybe theoretical but important, that systemically blocking IL-6 with tocia might paradoxically shift the inflammatory balance within the CNS or somehow mask the true progression of the neurotoxicity, potentially even worsening the CNS disorder in some cases. So the rule is clear. For ICANS, the primary drug is the steroid.
Got it. Steroids for ICANS. Now, what if a patient presents with just grade 1 ICANS? Maybe their ICE score dropped from 10 to 8. What supportive measures are needed immediately, even if high-dose steroids aren't universally mandated right at grade 1 by all protocols?
Even grade 1 ICANS is a significant warning sign. Things can progress quickly. So immediate supportive care must include rigorous seizure precautions and fall precautions. The patient might seem only mildly confused, but their risk is elevated.
Seizure and fall risk, definitely.
And because seizures can sometimes herald a rapid clinical decline in ICANS, many protocols strongly recommend initiating seizure prophylaxis as soon as ICANS grade 1 is detected. Typically, that's with levetiracetam, Keppra, often dosed at 500 milligrams PO or IV every 12 hours.
Prophylactic Keppra for grade 1 ICANS. Okay. And if, unfortunately, the patient progresses to life-threatening grade 4 ICANS, unarousable, maybe signs of cerebral edema,
Then it's an ICU emergency. They likely need intubation for airway protection. And just like with grade 4 CRS, they need the maximum pulse dose steroid. Methylprednisolone, 1,000 milligram IV daily, again, usually for at least 3 days, to try and quell that severe CNS inflammation.
same high-dose Solimedrol as for grade 4 CRS, but for a different reason, hitting the brain inflammation hard.
Exactly.
Okay, now here's arguably the toughest clinical scenario, the concurrent challenge. The patient develops, say, grade 2 CRS and grade 2 ICANS at the same time. They need tocilizumab for the systemic fire, the low BP, the oxygen need, but they also need steroids immediately for the brain symptoms, the ICANS. How does the IOET navigate this tightrope? What's the rule?
This is where that specialized training and clear protocols matter most. Because a siloed approach, just treating one or the other first, could be fatal. The guiding principle is crystal clear across guidelines. If ICANS is grade 2 or higher, corticosteroids must be initiated immediately.
The brain takes precedence.
The brain takes absolute precedence. You must give the dexamethasone, that 10 milligram IV Q6 or residual usually. Now, you can, and often should, administer the tocilizumab concurrently at the same time to address and stabilize the systemic hypotension and hypoxia being driven by the CRS component.
So give both?
Yes, give both if both syndromes are grade 2 plus FARAS. But tocilizumab must never be given alone in this concurrent scenario if the ICANS is grade 2 or higher. The steroids must accompany it to protect the central nervous system. That is non-negotiable.
Steroids are mandatory if ICANS is grade 2 plus TLA, even if you also give TOCI for CRS.
Got it. Finally, what happens if these standard therapies fail? What if the CRS or the ICANS becomes refractory to the IL-6 blockade with TOCI and even high-dose steroids? Are there other agents we can turn to?
Yes. Thankfully, there are options emerging for refractory toxicities, although the evidence base is still evolving. When things are refractory, we need to start targeting alternative inflammatory pathways. The most prominent alternative agent right now, especially because it seems to help with both refractory CRS and refractory ICANS, is anakinra. Anakinra. What is that, and why is it useful in refractory cases, particularly for ICANS?
Anakinra is an interleukin-1 receptor antagonist. IL-1 is another important pro-inflammatory cytokine involved in these cascades. But what makes anakinra potentially unique and valuable here, especially compared to tocilizumab, is its structure.
How so?
Anakinra is a smaller protein, and crucially, it has demonstrated an ability to cross the blood-brain barrier, at least to some extent.
Ah, so it can get into the brain, unlike toci.
It appears so, and that's why it's shown promise for refractory ICANS. It might be able to target the inflammation directly within the CNS that the steroids in toci haven't fully controlled. The typical dosing is something like 100 milligrams given intravenously or subcutaneously, maybe every 6 to 8 hours.
Interesting. Anakinra for refractory CRS and ICANS because it hits IL-1 and crosses the BBB. Are there other options, say just for refractory CRS?
Yes. For refractory CRS specifically, there's also ciltuximab. This is another monoclonal antibody, but instead of blocking the IL-6 receptor like tocilizumab, ciltuximab binds directly to the IL-6 cytokine itself, neutralizing it in circulation.
So it mops up IL-6 directly.
Right. It can be effective for refractory CRS, but, and this is important, ciltuximab, like tocilizumab, is a large antibody and does not effectively cross the BBB, so it is explicitly not recommended for treating ICANS. It's really reserved for refractory systemic CRS only.
Okay, so ciltuximab for refractory CRS, anakinra potentially for both refractory CRS and ICANS. And we should probably also mention the downside of all these potent anti-inflammatory drugs, especially the high-dose steroids.
Absolutely. While high-dose steroids are essential life-saving tools here, they're definitely not without cost. They significantly increase the patient's risk of serious opportunistic infections, bacterial, fungal, viral. And there's also a concern, backed by some data, that prolonged high-dose steroids might potentially blunt or delay the anti-tumor efficacy of the CAR T cells themselves. So it's a balancing act. You need aggressive monitoring for infections, and you need to taper those steroids as quickly as clinically safe once the toxicity is controlled.
Yeah.
Successfully implementing these really complex, high-stakes protocols, managing CRS and ICANS safely, requires an institutional commitment that goes far beyond just, printing out a guideline and handing it to people.
Right. It's not just about having the knowledge.
No, it demands significant system redesign. And it demands fostering a profound, deeply ingrained culture of safety throughout the institution.
So for an institution listening, maybe they're starting a CRT program or looking to improve their existing one. What are the key infrastructural recommendations that really need to be formally adopted to do this well?
Okay, a few non-negotiables come to mind based on the sources. First, the formal adoption of the ASTCT grading criteria across the board. Everyone uses the same definitions. Coupled with that is the non-negotiable mandate for that proactive, minimum, twice-daily ICE score assessment for every single patient. It has to be policy.
Standardize the assessment and monitoring. Got it.
Second, establishing that specialized rapid response capability. We talked about whether you call it an IOET or something similar. It needs to be available 224/7, staffed with specifically trained personnel, and critically, it needs delegated authority to act quickly based on the protocols.
Dedicated, empowered response team. Okay.
And third, integrating those EHR-based standardized order sets, SOSs, as the default mechanism for ordering treatments during an RRT activation. These SOSs must eliminate the need for risky handwritten orders or free texting complex regimens. They need to reduce decision variance when the pressure is on.
Embed the protocols in the workflow with SOSs. Makes sense. Now, how do you ensure the staff, the nurses, the doctors, the pharmacists are truly ready to execute these protocols? Especially since, hopefully, these severe grade 3 and 4 events are relatively rare, but they require near-perfect execution when they do occur.
That's a huge challenge. The roadmap to competency here relies heavily on both robust education and practical experience, or at least simulated experience.
Education and practice.
Right. All staff involved bedside nurses on the oncology units, critical care fellows and attendings, pharmacists. They all require mandatory interdisciplinary training. This needs to cover the complex pathophysiology we discussed, the nuances of the grading systems, the RRT triggers, and the specific drug algorithms in the SOSs.
So everyone gets the foundational knowledge.
Yes, but just reading slides or listening to lectures is honestly insufficient for these kinds of high-acuity, low-frequency events. Institutions must invest in high-fidelity, simulation-based training. Yes. Using realistic mannequins, simulated patient scenarios. This allows the actual clinical teams, nurses, docs, RTs together to practice recognizing the subtle drop in the ICE score, practice calling the RRT correctly, practice initiating the differential diagnosis workup quickly, and practice deploying the right SOS smoothly, all in a safe, controlled environment where they can make mistakes and learn without harming a real patient.
It builds the muscle memory.
Exactly. It builds the muscle memory and the teamwork needed for a rapid, coordinated, and importantly, non-hierarchical response when the real event happens under pressure.
You mentioned non-hierarchical communication there. How does the overall culture of safety within the institution directly support the success of the RRS or IOET in this specific setting?
It's absolutely fundamental. The efficiency and effectiveness of the RRS really hinges on psychological safety. Think about it. The bedside nurse is usually the first line of defense. They're the ones doing the ICE scores, noticing the first subtle changes. If that nurse feels intimidated or fears criticism or pushback for calling the RRT based on, say, a grade 1 ICANS trigger or even just a subjective clinical concern, if they hesitate because they're worried about bothering the team,
then the system fails. The delay could be critical.
the system fails. The institution must actively foster a culture where activating the RRT for a CAR-T patient concern is viewed as a necessary, expected, and valued safety check, not as an interruption or a sign of panic. Success here means seamless, non-judgmental communication. The frontline nurse needs to feel completely safe and empowered to speak up and activate the response immediately without fear of repercussions.
Flattening the hierarchy in moments of crisis.
Precisely.
And finally, to make sure this high standard of care is actually maintained over time and even improved, you need some kind of feedback loop, right? How do you achieve that?
Absolutely. Continuous quality improvement, or QI, is essential. You can't just set up the system and assume it's working perfectly forever.
We need to check and adjust.
Right. This means meticulous data tracking. For example, institutions should be measuring key process metrics, like the time from an RRT trigger, like that ICE score drop, to the actual administration of the first dose of tocilizumab or steroids. Are there delays? Where are they occurring?
Tracking time to treatment. Okay.
And critically, after every single RRT activation for a CRS or ICANS event in a CGT patient, there must be a structured post-event debrief.
Debriefing after the event.
Yes. And these debriefs are not about assigning individual blame. That's counterproductive. They are exclusively focused on identifying systems issues. Was there a pharmacy delay in getting the drug? Was the communication protocol unclear? Did the wording in the SOS lead to confusion? Was the equipment needed readily available?
Looking for system flaws, not finger pointing.
Exactly. This continuous analysis, using frameworks like Plan to Study Act, PDSA cycles, allows the protocols to be refined, the SOSs to be updated, the training to be adjusted, and the overall institutional safety systems to mature and improve over time. It's a constant learning process.
Wow. This has been an incredibly detailed and I think really practical look at managing some very high-stakes medical emergencies. Let's try and briefly recap those major takeaways for you, our listener.
Okay.
First CR cytokine release syndrome is that systemic fire. It's primarily driven by activated myeloid cells like macrophages churning out cytokines, with interleukin-6, IL-6 being the main culprit. Therefore, the primary targeted therapy is tocilizumab, which blocks the IL-6 receptor.
Right. CRS is systemic, think IL-6, think TOCI.
Then there's ICANS immune effector cell-associated neurotoxicity syndrome. This is a distinct CNS disorder happening inside the brain. It seems driven by that initial blood-brain barrier disruption followed by localized microglial activation.
Right.
And because it's in the brain, the primary treatment is high-dose corticosteroids like dexamethasone, which can penetrate the BBB.
Exactly. ICANS is CNS, think BBB disruption, think localized inflammation, think steroids first.
And remember, the absolutely foundational surveillance tool for catching ICANS early, the ICE score. That simple 10-point assessment done at least twice daily is your indispensable early warning system. Any drop from baseline needs immediate attention.
Don't ignore the ICE score. It's critical.
And finally, that tricky concurrent scenario. If a patient has both grade 2 or higher, CRS and grade 2 or higher ICANS happening at the same time, the rule is non-negotiable. Corticosteroids must be initiated immediately to protect the brain. Tocilizumab can, and often should, be given concurrently to manage the systemic CRS, but the steroids are mandatory for the ICANS component.
Brain first. Steroids are a must if ICANS is grade 2 plus love.
Okay, so we've learned what it takes organizationally and clinically to manage what you called a biological wildfire. What does this intense level of organizational discipline, this focus on standardization and rapid response, what does it tell us maybe about healthcare systems more broadly, even outside the specialized world of cellular therapy?
That's a really interesting question. Our sources and just clinical experience consistently highlight that an institution's ability to safely and successfully manage these acute, highly complex toxicities, CRS and ICANS, is actually a powerful indicator of its overall organizational health and maturity.
How so? Like a stress test for the system.
Kinda, yeah. Think about the discipline required to create that specialized RRS or IOET, to mandate objective, frequent screening like the ICE score, to develop and enforce the use of actionable, non-variant standardized order sets, to truly foster that non-hierarchical communication needed for immediate, safe response.
It takes a lot of coordination and commitment.
It is a huge amount. And that entire structure, the standardization, the intense multidisciplinary collaboration, the focus on system reliability, the psychological safety for staff, it really transcends just oncology or cellular therapy. It becomes, in a way, a blueprint for achieving excellence in any high-acuity care setting with rapid, protocol-driven, team-based action that saves lives.
So the lessons learned here have broader applicability.
I absolutely believe so. So, the provocative thought I'd like to leave you, the listener, with today is this. Reflect on the core principles we discussed, particularly that idea of using objective, sensitive triggers like a small drop in a score and truly empowering frontline staff to activate a specialized response team based on those triggers without delay or fear. Consider, how can adopting those same standards of hyper-standardization, objective monitoring, rapid response protocols, and fostering that culture of safety, how could applying those principles dramatically improve outcomes and safety protocols in your own professional environment? Even if it feels far removed from the world of CAR T-cell therapy, the principles of managing risk and responding effectively are often universal.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.